Hey guys, it's Valerie Oakland and I chose to do my master's thesis on corneal ulcers. I decided to choose corneal ulcers because I'm not only interested in eyes, but I am also a contact lens wearer. Contact lens use is the major cause associated with the formation of corneal ulcers. In this PowerPoint, we will go over some general features of corneal ulcers, the clinical assessment, how to diagnose, treatment plan, and prevention of corneal ulcers. Now we'll talk a little about the etiology and pathophysiology of corneal ulcers. Over the years, contact lens use has become increasingly more popular. From the 1950s to the 1980s, there has been a huge shift in contact lenses being the major cause of corneal ulcers. Corneal ulcers are defined as an ulceration of the corneal epithelium with underlying inflammation of the corneal stroma. Contact lenses break down the barrier protecting the eye surface, which encourages microbe accumulation. This then allows a microbial film to form on the surface of the eye lens. The most common microbes associated with corneal ulcers are Staphylococcus aureus, Pseudomonas aeruginosa, and coagulase negative Staphylococcus. When a patient has a corneal ulcer, they will experience a range of symptoms. Majority of the patients will have scleral injection or redness in the whites of the eye. Normally they will experience excruciating pain, which will lead them to go to the doctor in the first place. Other things that the patient may experience are tearing of the eye, swelling of the eyelid, photophobia, and importantly, decrease in visual acuity. Since corneal ulcers can lead to blindness, a decrease in visual acuity is particularly important to note. On physical examination, a provider will first need to directly visualize the eye and then perform a pen light examination. The provider may see a hazy opacity on the cornea of the eye or a hypopyon, which is white cells in front of the lens. Then the provider will need to perform a visual acuity examination using a Snellen's chart. This allows the provider to see how decreased a patient's vision is, which can lead to poorer prognosis. Then the provider will administer fluorescein dye to the eye, which helps to illuminate the hazy opacity. If anything concerning is found on any part of the physical examination, then an ophthalmologist must be consulted due to the high incidence of permanent vision loss. Even though corneal ulcers can be diagnosed clinically, they can be confirmed with either a gram stain or a culture of the microbes. The gram stain will primarily show what bacteria is affecting the ulcer. The culture can show not only the type of microbe affecting the eye, but antibiotics that the microbe is susceptible to. This helps with the treatment plan and ultimately ridding the cornea of the bacteria. Corneal ulcers are primarily treated with topical regimens such as eye drops. The most common treatment regimen primary care providers give are topical fluoroquinolones, such as moxifloxacin or gadafloxacin. These are the two most common topical antibiotic drops due to their added mycobacteria coverage. Topical cephalosporins may be also used if the gram stain is found to contain gram-positive cocci like Staphylococcus aureus. If symptoms have not resolved and the culture is found to have MRSA or methicillin-resistant Staphylococcus aureus, then vancomycin may be required. It is important to recognize that topical fluoroquinolones are considered the first-line treatment. There have also been some studies that have shown that topical corticosteroids can improve a patient's visual acuity by 2 to 3 days compared to a placebo. It is important to recognize that an ophthalmologist must administer topical corticosteroids. The best way to prevent corneal ulcers are for patients to be educated on the proper lens hygiene. The provider should explain the importance of preventing a corneal ulcer and how it could potentially cause permanent blindness. The provider should educate the patient on not sleeping with contact lenses, replacing lenses regularly, and using only sterile solution to store contact lenses. This means that the patient should not use tap water, bottled water, or saliva to remoisturize the contact lenses. Throughout the slideshow, we learned a little more about the significance of corneal ulcers and how they can affect a patient's activity of daily living by potentially causing permanent visual loss and things that we as providers can do to help decrease the incidence. Here are my references. Thank you so much for listening, and I hope you have learned something new.